Imagine a patient comes to you with a suspicious, palpable mass in their groin. You run the tests, you do a biopsy, and the pathology report comes back with just a startling diagnosis.
Oh, primary breast carcinoma.
Exactly. Primary breast carcinoma. So, how does a tumor originating in the chest manifest as a physical swelling down in the pelvis? If you are a resident preparing for your MRCS exam, your membership of the Royal College of Surgeons, that is exactly the kind of systemic mechanistic puzzle you have to solve.
You really do. I mean, you're stepping into the surgical arena now. Anatomical blueprints have to come alive in your head. If you don't understand the underlying functional architecture, you are just going to get lost.
You are. And that is exactly what we are breaking down today. So welcome to this focused, high-yield deep dive. No fluff today, no long introductions. We are going to rapidly test and explain the essential examinable anatomy of the upper limb and breast.
It's all about high-stakes anatomy.
Right. But before we start firing questions, I have a direct instruction for you. Head over to medsynclimited.com right now. You need to get your surgical simulation kit. Specifically, make sure you grab the suturing kit and the microsurgery instruments.
Yeah, you really can't master the physical, tactile skills of surgery just by listening to us talk.
You can't. You need the repetitions. So that's medsynclimited.com. Also, take a second to press follow on the show to catch more of these revision deep dives. And if you learned something valuable today, leave us a rating.
Sounds good.
All right, let's establish the dynamic. We're going to tackle the specific anatomical presentations you'll face, and we're going to extract the why and the how behind them. Let's start proximally up at the shoulder.
We have to start proximally because, proximal stability dictates distal function.
Right.
You just cannot have a highly dexterous, precise hand if the shoulder girdle anchoring it to the thorax is functionally compromised.
Makes total sense. So let's look at the bony framework first. The scapula and the humerus. Now, on the humerus, there are two massive red flags for fractures, right? The surgical neck proximally and the spiral groove running down the posterior shaft.
Yeah, classic injury sites.
We'll get to the nerves trapped against those bones in a minute, but let's look at the glenohumeral joint itself. Textbooks always compare it to like a golf ball sitting on a tee.
Which is, it's okay, but it's a bit rigid.
It's far too static. I think you should think of the shoulder joint more like a seal balancing a beach ball on its nose.
I like that.
Because the bony structure, that shallow glenoid fossa, it does almost nothing to actually hold that massive humeral head in place.
That is a much better way to visualize it, yeah. The joint is entirely dependent on the active, dynamic micro-adjustments of the surrounding muscular envelope.
Right.
Because the glenoid fossa is only, slightly deepened by a cartilaginous ring called the labrum glenoideal, but without the rotator cuff muscles actively pulling that humeral head into the socket.
It would just pop out.
Exactly. The joint would dislocate with basic daily movements.
So we have the rotator cuff, the supraspinatus, infraspinatus, and teres minor, which all insert into the greater tuberosity on the lateral side of the humerus.
Yep.
And then you have the subscapularis inserting into the lesser tuberosity anteriorly. So here is your classic MRCS scenario. We know the supraspinatus initiates the first 15 degrees of shoulder abduction.
Right, the very beginning of the movement.
So if a patient presents with a completely ruptured supraspinatus tendon, how do they get their arm up? You can't just bypass the physics of the joint.
Well, you can't bypass physics, no, but you can use gravity as a biomechanical cheat code.
A cheat code?
Yeah. The patient develops very specific trick movement. They actively tilt their torso completely over to the injured side.
Oh, so they just lean over.
Right. By leaning laterally, gravity naturally causes the injured arm to just swing away from the trunk. This passive swing basically covers that initial 15-degree requirement.
Wow. So they essentially drop the arm into abduction without firing a single muscle in the shoulder.
Precisely. And once the arm is hanging slightly away from the body, the massive deltoid muscle can take over.
Because it needs that initial angle.
Exactly. It's perfectly functional, but it usually needs the arm already abducted slightly to get a mechanical advantage. So it catches the relay baton, fires, and powerfully abducts the arm up to 90 degrees.
That makes perfect sense. But okay, what if the supraspinatus tendon isn't ruptured, but it's just severely inflamed? Let's break down supraspinatus tendinitis and the infamous painful arc of movement. Patients complain of agonizing pain, but only during a very specific window of motion.
Yeah, the painful arc. It occurs precisely between 60 degrees and 120 degrees of abduction.
Why that specific window?
To understand why, you have to look at the immediate bony roof over the joint. The supraspinatus tendon has to pass over the apex of the shoulder, basically threading the needle beneath the bony acromion and the tough coracoacromial ligament.
Ah, the pinch point.
That's it. When the tendon is swollen and inflamed, it loses its clearance. Below 60 degrees of abduction, the inflamed portion of the tendon hasn't yet reached that tight subacromial space.
So there's no impingement yet.
Right, so there is no pain.
Uh,
But as you lift the arm past 60 degrees, that swollen tendon is forcefully dragged under the acromion. It gets physically crushed against the bone and the ligament.
Ouch. And then, miraculously, once they push past 120 degrees, the pain just vanishes. Why is that?
Because at 120 degrees, the greater tuberosity of the humerus, where the tendon attaches, has fully cleared the acromion.
It just tucks under and past it.
Exactly. It's essentially rotated past the danger zone. The tendon is no longer being compressed, so the pain subsides. It is pure mechanical impingement.
Which proves why knowing the bones and tendons is crucial. But I mean, it also brings us to the wiring, the brachial plexus. Because those fractured bones we mentioned earlier, the surgical neck, the spiral groove, they don't exist in a vacuum.
No, they don't.
When a bone breaks, the nerves winding tightly around them get traumatized.
And the brachial plexus is frequently tested because it really separates the residents who simply memorize lists
Yeah.
from those who, truly understand neural mapping.
I think of the brachial plexus like a tremendously complex railway interchange.
Yeah, absolutely.
You start with the roots, the anterior primary rami of spinal nerves, C5 to T1. They merge into trunks in the neck, split into divisions behind the clavicle, and reform into cords down in the axilla.
And a blockage or derailment at any specific station predictably reroutes or entirely halts the sensory and motor traffic downstream.
Exactly. So the exam demands that you trace a distal physical deficit backward to find the exact site of the derailment. Let's test that. Upper root damage, C5 and C6.
Okay.
This often happens from forced downward traction on the arm, right? Like a difficult childbirth pulling the head away from the shoulder. This gives you Erb's paralysis.
Yeah, Erb's palsy.
The patient presents with their arm hanging limply at their side, completely pronated, with the palm facing backward in that classic waiter's tip position, which is, deeply ironic because as a surgical resident, you're definitely not getting tipped.
Sad but true. But the irony aside, the mechanics are devastating.
Yeah.
You have knocked out the abductors and the lateral rotators of the shoulder.
And the supinators.
And supinators of the forearm, yeah. So gravity and the unopposed medial rotators pull the arm into that rigid, twisted posture.
Got it. And if we move down the arm to those humerus fractures we talked about, break the surgical neck, you take out the axillary nerve, the deltoid muscle atrophies, and you lose sensation over the lateral shoulder, the so-called badge area.
Right.
Break the midshaft at the spiral groove, you trap the radial nerve, paralyzing the extensors of the forearm, and you get a profound wrist drop.
Classic presentation.
Those are the basics. Let's push into a more complex presentation. Klumpke's paralysis.
A phenomenal example of antagonist and agonist imbalance.
Klumpke's is a lower root injury, specifically tearing C8 and T1, usually from sudden upward traction, like grabbing a tree branch to stop a fall.
I have two questions here. First, why does a lower root injury specifically present with a claw hand?
Okay.
And second, how on earth does forcefully pulling someone's arm tie into Horner syndrome, which affects the eye?
Let's break down the claw hand first, because it is entirely about the functional equilibrium of the hand just being destroyed. The T1 nerve root is the primary power supply for the intrinsic muscles of the hand via the ulnar and median nerves.
We are talking about the interossei and the lumbricals.
Yes, the fine-tuning muscles. Normally, these intrinsic muscles do a very specific job. They flex the knuckles, the metacarpophalangeal joints, and they extend the interphalangeal joints in the fingers.
Okay, so they flex the base and straighten the tips.
Right. When T1 is torn, those intrinsic muscles are utterly paralyzed. They die.
So if the intrinsic muscles are dead, what forces the hand into that rigid claw shape?
The heavy-duty cables of the forearm take over.
The long flexors and the long extensors of the forearm are suddenly unopposed. It is a brutal tug of war where the moderator has just left the room.
That's a great way to put it.
The long extensors aggressively extend the knuckles, pulling them backward. Meanwhile, the long flexors, the flexor digitorum profundus and superficialis, vigorously flex the finger joints, curling them inward.
Because the intrinsic muscles cannot provide their normal action to counteract this, the hand gets locked into a rigid, useless claw.
Exactly. It's unopposed pull.
That perfectly explains the hand. Now, connect a torn nerve in the armpit to the eye. What is the Horner syndrome connection?
That is pure anatomical collateral damage. The sympathetic chain, which provides sympathetic innervation to the face and eye, runs intimately close to the T1 nerve root in the neck.
Oh, I see.
So when a patient suffers severe upward traction that violently tears T1, that kinetic force often simultaneously avulses or severely stretches the sympathetic fibers right next to it.
So you lose sympathetic tone on that side of the face?
Exactly. Without sympathetic input to hold the eyelid fully open and keep the pupil dilated, you get the classic triad. Ptosis, which is a drooping eyelid, meiosis, a constricted pupil, and anhidrosis, a lack of sweating on that side of the face.
Which really reinforces the rule that nerves do not travel alone. If you pull hard enough to rip a nerve root, you have to worry about the vascular highways running parallel to it.
Always.
So let's trace those pathways to the veins and arteries. The superficial veins are crucial for everyday clinical practice. Cannulation, drawing blood, establishing access.
They are the workhorses of the ward, but they carry distinct surgical implications.
Like the cephalic vein at the wrist. It sits securely in the subcutaneous tissue just behind the radial styloid bone. It is incredibly constant in its anatomical position. Why is that constancy so prized by vascular surgeons?
Because that reliable position makes it the premier site for creating a radiocephalic fistula.
The Seminobrescia fistula.
Exactly, for patients requiring long-term hemodialysis. The radial artery lies in perfect close proximity to that reliable vein, allowing the surgeon to seamlessly connect the high-pressure arterial flow directly into the venous system.
But let's travel up the arm to the elbow, the antecubital fossa. You have the cephalic vein laterally, the basilic vein medially, and the median cubital vein bridging them across the front of the elbow.
Right.
We always warn junior staff about the dangers of injecting irritant drugs or patients injecting illicit substances into these specific elbow veins. If someone is blindly jabbing a needle into the median cubital vein, what anatomical trap is waiting for them?
The trap is massive, catastrophic arterial ischemia.
Wow.
Now, normally, the body tries to protect us.
Right.
There's a tough fibrous band called the bicipital aponeurosis that acts as a physical shield. It separates those superficial veins from the deep, pulsating brachial artery lying directly beneath them.
So normally a needle goes into the vein, hits that fibrous shield, and stops before hitting the artery.
Right, exactly. However, human anatomy is highly variable. A significant percentage of people have a superficially placed aberrant ulnar artery.
Oh, no.
Yeah. Instead of running deep, this aberrant artery runs right alongside or even superficial to that protective aponeurosis.
Wait, so if I'm a junior doctor trying to cannulate a tricky median cubital vein and I accidentally hit that aberrant superficial artery instead, I'm not just causing a nasty bruise, I'm injecting an irritant straight into the main arterial supply of the forearm.
It is a nightmare scenario. The irritant damages the endothelial lining of the artery, causing massive arterial spasm and immediate thrombosis. The blood supply to the discal limb just shuts down.
That's terrifying.
If it's not recognized and treated urgently, you can literally lose the forearm and hand to ischemic necrosis.
Highly examinable point there. And while we are on the arterial trunks, we cannot ignore the axillary artery. The textbooks love to point out that it is divided into 3 distinct parts by the pectoralis major muscle overlying it.
Right. Part 1 has 1 branch, Part 2 has 2 branches, Part 3 has 3 branches.
But why does a surgeon actually care about those divisions?
Because it dictates the survival of the limb if you have to clamp the artery.
Okay, how so?
If the axillary artery is severely damaged and you have to ligate it, you must know where the collateral circulation loops around the shoulder joint. If you clamp between the wrong branches, you cut off the collateral detour and the arm dies.
It's all about the routing. Let's follow those neurovascular bundles all the way down into the hand. Because the hand is where minor distal infections can rapidly escalate into surgical emergencies. We're talking about the fascial spaces, the synovial sheaths, and severe sepsis.
The hand is an absolute masterpiece of fascial compartmentalization.
I liken the fascial compartments of the hand to the watertight bulkheads of a submarine.
That's a great analogy.
They are brilliantly designed to be protective, separating and containing the vital sliding tendons and delicate nerves. But that exact same design becomes a nightmare when an infection takes hold and pressure begins to build up inside a closed, unyielding space.
It just becomes a pressure cooker?
Right. Let's look at the synovial tendon sheaths. An infection in the index, middle, or ring finger is usually confined locally to that specific digit. But the synovial sheath of the thumb, which is the radial bursa, and the synovial sheath of the little finger, the ulnar bursa, are different.
Very different.
They extend proximally all the way into the palm, diving deep under the flexor retinaculum at the wrist.
And crucially, in many patients, the radial and ulnar bursae physically communicate with each other at the wrist.
Wait, they connect.
Yes, this means a seemingly minor puncture wound on the thumb can introduce an infection that tracks all the way down the radial bursa, crosses over in the wrist, and travels straight up the ulnar bursa into the little finger.
A completely interconnected bulkhead failure. It creates a massive, devastating horseshoe abscess that threatens to destroy the gliding mechanisms of the entire hand.
It's incredibly dangerous.
Which brings me to a highly specific, classic MRCS question regarding the fingertips. Let's look at the distal pulp spaces, the fleshy pads of the fingers. If a patient gets a severe pulp space infection, known as a felon, the pressure inside that closed space skyrockets.
Right.
This pressure causes arterial thrombosis, leading to rapid, irreversible necrosis of the distal phalanx bone. But here's the paradox. Why is the base of that distal phalanx bone miraculously spared from the necrosis while the shaft dies?
This is a beautiful example of how microscopic vascular anatomy dictates macropathology. The pulp space of the fingertip isn't just an open bag of fat. It is tightly packed fat trapped between tough fibrous septa that run from the skin straight down, anchoring rigidly into the periosteum of the bone.
It's like a structural honeycomb.
Precisely. And the arterial vessels supplying the shaft of the distal phalanx are forced to physically thread their way right through these dense, unyielding fibrous compartments.
So they're trapped.
Exactly. When the space fills with pus and swells, the fibrous septa don't stretch. The pressure inside shoots up, physically strangling those vessels against the connective tissue. The vessels thrombose, and the shaft of the bone starves and dies.
But the base of the bone survives because of its plumbing route.
Yes. The specific arterial branch that supplies the base of the distal phalanx branches off the digital artery early.
Oh, before it reaches the pulp space.
Right. It simply does not pass through that pressure chamber. Therefore, it escapes the strangulation, remains patent, and the base of the bone survives the infection.
It's all about precisely where the branch pops off. We see the exact same principle in the carpal tunnel. You have to know the boundaries. The tough flexor retinaculum forming the roof, the carpal bones forming the floor.
Yeah, another unyielding space.
If pressure builds up inside that tunnel, the median nerve gets crushed. The patient loses function in the thin-on muscles of the thumb and loses sensation to the radial 3.5 digits. But the sensation to the lateral palm itself is completely spared. Why?
Because the palmar cutaneous branch of the median nerve pops off before it enters the tunnel.
Exactly. It travels superficially over the roof.
It bypasses the bottleneck entirely.
Which naturally transitions us away from the distal bottlenecks to the primary routing center for the entire upper limb, the gateway, the axilla and the breast lymphatics. To wrap up our upper limb revision, we have to look at how it physically connects back to the thorax.
It's a vital transition zone.
I visualize the axilla as a pyramidal toll booth. Every single structure traveling from the neck and thorax must pass through this specific space to reach the arm.
And you must be able to define the walls of that toll booth surgically.
Exactly. It has an anterior wall made of the pectoral muscles, a posterior wall formed by the latissimus dorsi, teres major, and subscapularis. It has a medial wall made of the rib cage and the serratus anterior muscle, and a narrow lateral wall at the bicipital groove of the humerus.
But for the general surgeon, the most critical structures within the fat of that pyramidal space are the axillary lymph nodes.
Oh, without a doubt.
They're intimately tied to the lymphatic drainage of the female breast, and understanding their layout is just non-negotiable.
Surgeons map these nodes strictly in relation to the pectoralis minor muscle. Level 1 nodes are located below and lateral to the inferolateral border of pec minor. Level 2 nodes are tucked directly behind the muscle. Level 3 nodes are situated above its superior border, right at the apex of the axilla.
This isn't just trivia either.
No.
Mapping these levels dictates the morbidity of an axillary clearance surgery. Going after level 3 nodes at the apex means venturing into incredibly dangerous territory, working intimately close to the delicate axillary vein and major nerve cords.
And that surgical mapping is heavily tested in the context of breast carcinoma. Let's look at the breast tissue itself, composed of fat, glandular tissue, and fiber septa. When you are conducting a clinical breast examination, you are looking for specific visual red flags. One of the most classic signs of underlying malignancy is dimpling of the skin, often referred to as peau d'orange. Mechanistically, what anatomical structures are physically pulling on the skin from the inside to create that tethered, dimpled effect?
You have to look directly at the ligaments of Astley Cooper.
Okay.
These are the strong, suspensory fibrous bands that run from the deep fascia of the chest wall, weaving all the way through the breast tissue to attach directly into the subcutaneous tissue and the dermis of the skin. They are what give the breast its structural support and contour.
They act like internal anchors.
Yes. When a malignant tumor infiltrates the breast tissue, it inevitably invades these ligaments. The cancerous tissue causes an aggressive inflammatory and fibrotic reaction, and this fibrosis makes the ligaments of Astley Cooper physically contract and shorten.
And because those anchors are attached to the skin,
And as they contract and pull inward, they physically drag the overlying skin down with them. It creates that visible, localized dimpling on the surface.
and while we are examining the internal architecture, it's vital to remember the functional layout of the lactiferous ducts. The breast contains 15 to 20 lobules of glandular tissue, and each one drains into a lactiferous duct that converges radially toward the nipple, like the spokes of a wheel.
And that dictates your surgical approach.
Exactly. If you must make an incision into the breast tissue to drain an abscess, you make it radially. Why? To slide between the spokes. You are specifically avoiding transecting multiple converging ducts and destroying the functional drainage of the gland.
Every incision must respect the functional lines of the anatomy beneath the skin.
Every diagnosis relies on it. Which brings us to the end of our rapid-fire revision of the upper limb and breast. We've covered the mechanical tricks of the rotator cuff, the devastating routing failures of the brachial plexus, the vascular traps, the submarine bulkheads of the hand, and the structural anchors of the breast.
But before we wrap, there is one mind-bending consequence to all this lymphatic mapping that residents rarely consider until they see it in the clinic.
Oh, what's that?
Well, we discussed the axillary nodes, but the lymphatic system is a pressurized hydraulic network. We know the lateral part of the breast preferentially drains to those axillary nodes, and the medial part drains inward to the internal mammary chain. But what happens when a primary breast carcinoma becomes so advanced that it completely infiltrates and physically blocks those normal pathways of lymphatic drainage?
Well, the toll booth is closed. The fluid has nowhere to go.
But it doesn't just stop. It reroutes. The pressure forces the lymph to seek alternative channels, pushing the valves to fail. The tumor cells can be carried backward across the midline, seeding into the lymphatics of the opposite, healthy breast.
Wow.
They can cross over to contralateral axillary nodes, or, astonishingly, they can drain straight downward, traversing the superficial lymphatics of the abdominal wall, traveling all the way down to lodge in the inguinal lymph nodes in the groin.
Which brings us right back to our opening scenario. The diagnostic puzzle of a patient presenting with a primary breast cancer that first manifests clinically as a palpable mass in their groin.
It forces you to completely abandon the idea of a localized problem. Understanding the systemic anatomical connectivity, knowing that a mechanical blockage in the chest can manifest as a swelling in the pelvis, is exactly what separates a good resident who memorizes a textbook from a truly great surgeon who understands the living machine.
The static map fails, but the dynamic territory reveals the truth. That is why we study the mechanisms, the why and the how, not just the names. Thank you for joining us on this deep dive. If this session clarified a tricky concept for you, or if you have a specific anatomical mechanism you are still wrestling with for the MRCS, leave us a comment or a question below. And remember, hit follow so you don't miss our next session. Keep studying the blueprint, but never forget you are working on a living, breathing system. We'll see you next time.